So it's my pleasure to introduce Dr. Gregory Eastwood. Dr. Eastwood is University Professor of the State University of New York. He's a former president and dean of Upstate Medical University, and has also served as interim president of both Case Western Reserve and Upstate Medical Universities. He is a professor of bioethics and humanities at Upstate Center for Bioethics and Humanities and professor of medicine also at Upstate. Dr. Eastwood is author of many articles and book chapters, either as an author or an editor. Most recently, he wrote Finishing Our Story, Preparing for the End of Life, which was published by Oxford University Press in 2019, and you can probably find that at Barnes & Noble, or they will get it for you. I can personally recommend this gentle and readable book about a most important and sometimes difficult topic. Dr. Eastwood.
Well, Joel, thank you. You've been a good colleague for many, many years. Thank you for the introduction. Scott, thank you so much for your technical help. It's more than technical help. It's a psychological reassurance. And Jennifer, thank you for your leadership. I've experienced your leadership over a year now. And, and it's all good. Thank you. Thank you all who are on the board. You know, boards of volunteer organizations don't get paid anything, but you do get paid. We all get compensated by the joy and the satisfaction of what we're doing because it's something worthwhile. And those of you who are just tuning in, thank you for doing that. So right away, I'll tell you that I may be the expert who's giving a talk today, but each one of you is an expert on this topic. You know that. And it's not just because you are connected with the Funeral Consumers Alliance. It's because you have lived beyond, say, age 20 or 30, and you've had experiences with loved ones dying, and some very close, of course, maybe friends and so on. So you bring a certain experience and expertise. And you know, I'll tell you right now that one of the reasons why I do talks like this is to hear what you have to say. I always learn something new. So during my talk, it's a little bit like Julius Caesar. He wrote the Gallic Wars. He said all Gaul is divided into 3 parts. Well, my talk is divided into 3 parts too. And I will pause at the end of each part and ask you for your comments or questions if you have them. So there'll be ample opportunity for you to participate, and I would welcome that. Of course, if we were in person, I could sense a little better who might be a little restless and wants to say something, but I can only see 3 or 4 of you now at a time. So we will wait until the end of each section. So this is where I come from now. And if you look at that picture of all those nice people, that guy standing in the back row, second from the left, is familiar to you. So Joel is a member of the Center for Bioethics and Humanities. And we're a good group of people. We have several physicians. We have a couple of philosophers. We have one lawyer, Ed McCardle, over there on the left. We have an ethicist, and we have several staff. This is a book that Joel referred to. It was published 2 years ago, Finishing Our Story, Preparing for the End of Life. Of course, that was before the pandemic. So at the beginning of the book, I said nearly everything about dying is different than it was 2 or 3 generations ago. Not death itself, of course, that remains the same. But the process of dying, what happens during those days, months, even years before we die, has changed a great deal. It can be confusing and frightening. And then you can see the chapters there. I give a story, a personal story in the introduction about my first memory of when I was 3 years old and taking a long trip from Michigan to the mountains, small town in the mountains of Pennsylvania, where my grandmother had lived and died, and so on. And you can pass your eye through there. Dying isn't what it used to be. That's all about how things have changed. And the second chapter has to do with quality of life and how we factor that in, how we integrate that into our decisions, making our wishes known. You know all about this, healthcare proxy agents and so on. The fourth chapter has to do with people who get a little confused, particularly if they're in a hospital and things are going wrong or they think they're going wrong, and ethics consult is called. What does that all mean? What's the difference between an ethics consultation and an ethics committee and so on? In the fifth chapter, we talk about palliative care. In the sixth chapter, we talk about physician-assisted death or killing yourself by other means, such as what Diane Reen wrote a book about in terms of her husband's death. He died after not eating or drinking for about 10 days, and then finishing our story. So we're not going to go through everything, but that gives you a little taste of what that book was. And I asked you to remember what I said at the top there. It's taken several generations for these changes to occur, because during the pandemic, things have been speeding up. Here's one of my favorite comic strips, Pickles. It's about two older people. I identify very strongly with Earl and his wife Opal and their son, or the grandson, Nelson. Here's Earl and Nelson throwing pebbles into the pool. And Nelson says, "Grandpa, how long do you want to live?" And Grandpa says, "Oh, I don't know. I guess until I don't want to anymore." Little boy says, "Well, I hope you live as long as you want to." And Earl says, "I hope I want to as long as I live." And that is a very clever, very incisive look at what the dilemma is, isn't it? Of course, we think we want to live a long life, but we want to live a long life that we want to live. So this is what we're going to talk about over the next, I think, about 20 or 25 minutes. We'll see how COVID has affected the end-of-life experience, allocation of scarce resources using the example of ventilators, and finishing your story. So I wrote a blog about a year after the book was published for the Oxford University Press. So now that's a year ago. And now the COVID-19 pandemic has added its imprint on the end of life in a matter of weeks, not decades. It has or will touch nearly everyone in some manner. It has raised critical concerns about the allocation of resources, threatens to disrupt established practices of respecting individual autonomy and decision-making, and may affect not only a person and their loved ones at the end of life, but also how that person is honored after death. So COVID has certainly challenged health professionals. I think most health professionals have gotten used to it now. Maybe not. There's a lot of burnout. So what does it mean to be a nurse, a physician, a respiratory therapist, a social worker, a clerk who works either in an outpatient area or on an inpatient ward? What does it mean to work in that environment? You know, during the Middle Ages, during the plagues, what does it mean to be a physician who stayed there or didn't? So these issues are implied in that question. What does it mean to be a nurse? And many doctors and nurses and others have answered with remarkable loyalty and effectiveness. And you've read about the people who've gone down to the Javits Center, and or people have stayed where they are and have done extraordinary service. When I was in college, and you may have experienced this too, I took a philosophy course and I examined the ancient questions. Why am I here? What is my purpose? What am I supposed to be doing? Well, these questions have very practical significance for a nurse who's showing up to work every day and asking, why am I here? What am my purpose? What am I doing? And as I say, almost everyone has answered it in a very, very productive way. But also, COVID has raised a number of questions that not only are existential, but they're very practical, they're economic, social, and laden with our own values. First, what are the limits of personal freedoms? To what extent may we permit individual choices when they may harm others? This has a lot to do. We're still wrestling with this in our country, whether all of us will be vaccinated and why some of us who don't want to be vaccinated don't want that. It has a lot to do, of course, with the whole gun ownership, a lot of things that have existed since the beginning of our country. The second, are some deaths acceptable in order to save a sagging economy? I haven't heard a lot about this recently, maybe because the economy seems to be doing better, but even our president alluded to this about a year ago, our former president, that there might be a price in human life for the benefit of people at large in terms of stimulating the economy and getting back to normal behaviors. Third, should economic and social status determine preferential treatment? Of course, the history of the world is much of that, and some of that exists, and we'll go into that a little bit in the next section about allocation of ventilators. What is the, and related to this, at least in my mind, is if you broaden the focus beyond the United States, what is the responsibility of prosperous nations to poor nations? This morning in Syracuse Post-Standard, there was an article about now the surplus of vaccines. I mean, that's not really new, but it's dramatic, particularly in some areas of the country where people are less inclined to have vaccines. And should we send some of those somewhere else around the globe? And then the fifth one there, what is the cost of diminished attention to non-COVID issues? Again, in today's paper, and this keys off of an article I read in the Journal of the American Medical Association about 2 months ago, but today's Post-Standard talks about not only the increase in deaths due to COVID. Now, the numbers vary a little bit when you're talking about how many deaths since the beginning of COVID or how many deaths during calendar year 2020 or some other period of time. But there have been a lot of deaths, let's say 500 to 600,000 deaths attributed to COVID. But deaths to other conditions have increased too, particularly, and this is what the article this morning talked about, diabetes and heart disease. Why is that? It's thought to be because during the pandemic, people paid less attention to their diabetes or heart disease or whatever else was they were afflicted with, and so they didn't receive the appropriate care, and they died of those conditions. I have a family risk of colon cancer, and I get a colonoscopy every 5 years. Well, this time I waited a year. Okay, got it 2 weeks ago. Well, it occurred to me that, boy, if I had waited that year and something bad showed up on my colonoscopy, I would be very annoyed. Of course, it was normal, and I was pleased about that. So there are costs and risks that are not directly related to the COVID pandemic, but are indirectly related. It also has heightened our awareness of what we've known all along, what I basically talk about in the book, make our wishes known about healthcare decisions, appoint a healthcare proxy, attend to other personal matters. You know that already. But also has brought about some changes in the end-of-life experiences because of limited resources like ventilators. A person's previously expressed wishes about the end-of-life decisions might be overridden in the best interest of other sick people. We'll talk about that. Because of restrictive visiting policies, loved ones may not be allowed to be with a person when they die. You may have some examples of that. I'd like to hear them. I have some examples that I'll tell you. And because of constraints on funerals and memorial services, COVID reaches beyond death to affect the traditional celebrations and remembrances of the deceased. And in that same blog I referred to, I said COVID's heavy grip is evident on both sides of the moment that divides the end of life from eternity. Kind of a dramatic statement, but it's the truth. The end of life, while someone's still alive, has been very much affected by COVID, and after they die, still affected. So some of you may know Barb Krenzer. She had been in charge of our palliative care service at Upstate University Hospital, and about a year ago, well into the pandemic, and I was aware that University Hospital, with the help of our foundation, had purchased several hundred iPads to help communicate with patients who are in isolation, particularly not only those who are dying, but particularly those. And she responded to my email with really a poignant story. She says, families can have visual visits with patients, even if the patient is on a ventilator. The family can see the patient and feel like they're with them. This week, we had a confused cancer patient light up when she saw and could talk with both of her sons. Her delight and joy was so touching, both to her family and to her nurses and physicians. She was very comfortable going to God and could express that to her sons. The smiles and tears with the intimacy of her holding the iPad close to her face to see her sons was wonderful. So I'm going to stop right there. And this is the first pause, and ask if anybody has a question. And if you do, or maybe Scott, you monitor the chat, but if you do, just speak up because I can't see everybody. Or if you have a comment, a story, I'd love to hear it.
Yeah, if anybody has any questions, you can put them in the chat, or if you'd like to ask them personally, we can break off our screen share temporarily and have everybody up there. So feel free to unmute yourselves if you have any questions.
And if something comes up because I'm asking you to think about this, but we go on to the next section, please read the write it down and remember it, and we'll pick it up at another time.
Dr. Eastwood, my name is Maggie Reed, and I have a comment.
Yeah.
My husband passed away February 18th. He had a pretty massive stroke on January 26th. He went into upstate and was in neuro there. And at that point, they were just opening up in-person visitations for one family member.
Mm-hmm.
And so we were able to see him both on the screen, and I was able to go in person. When he was stepped down, then I lost my visitation again, but as soon as we went to comfort care, I was able to visit. And the difference between the iPad was wonderful compared to nothing,
Mm-hmm.
but it didn't hold a candle to being there in person, to be able to touch and to communicate in subtle ways that can't happen over a screen.
Yeah, yeah.
But I think that you know, it was a hard time to make decisions, and our decisions were clarified because we didn't have as many choices. It was like, okay, we can't go to Francis' house because their visitation is too restricted. Same thing with the nursing home. So we brought him home under hospice, which worked out very, very well. But he was very clear about what he wanted, and made everything a whole lot easier for us to decide.
Yeah. I'm glad that you were able to experience that when there was a little bit of relaxation in the visiting. You know, I've been on, let's call it, both sides of the administrative equation. I've been a practicing physician, not recently. Of course, I was one of the leaders at Upstate for a long time. And now I'm in sort of a middle position, along with Joel, as a faculty member in the Center for Bioethics and Humanities. And several of our colleagues here have been very concerned, or we all have been very concerned about the restrictive visiting policies. But I think because of my previous life, I could see the rationale for that. But several of my colleagues were active in loosening those up. And I'm glad at least you were at that cusp where you could experience some of that.
Yeah.
Well, I'll go on, and if you, oops. So let's talk about the allocation of scarce resources. Are we did I advance it?
Yes.
Okay.
Yep.
Something just happened where I couldn't forward, but there we are. Okay. So on that same blog, it was only 4 or 5 paragraphs, but boy, I got a lot in. When ventilators become scarce, by what criteria should we decide who gets one? We will need to move away from the primary focus on the individual patient to take into account the needs of the community, superimposing a public health perspective on the care of people. Now, you probably have thought about this, but if you haven't, it really it opposes directly two very fundamental principles that are held by most of us in this country. You know, the principle of autonomy, our own rights, and the principle of basically taking into account the needs of others and allowing for that and maybe modifying our own behavior. So this is I'm gonna examine that a little bit more. In 2015, New York State Department of Health promulgated ventilator guidelines. And that was because there were very serious influenza outbreaks in 05 and 09. And the primary goal of these guidelines were to save the most lives when ventilators are limited, but also in order to preserve the clinician's duty to care. Remember, the clinician, the doctor primarily, is your advocate, the patient's advocate, or should be. And so a triage committee decides when ventilators should be used. Now this again, you know, is it some committee that's going to decide for my doctor? You know, that's an immediate response. Well, the answer is yes, but I think it's modified. I'll tell you why. So with that as a background, that state policy in 2015, very quickly, right after the pandemic started, Upstate University Hospital developed its own policy. This is dated, I think, in May, a year ago. And it acknowledges and adheres to several ethical principles. The primary goal is to maximize the survival for as many people as possible. There's a fairness doctrine. You know, these allocations should be applied broadly, consistently, openly. Is committed to the compassionate care of all patients. And it acknowledges that it's not possible to make painful triage decisions in a way that everyone will be satisfied, but it does make decisions in ways that are transparent. In other words, a policy, if you know, it's available to anyone, and it's respectful and fair. So right off the bat, there are some ethically wrong allocation criteria. Demographic characteristics, and you can read them, race, ethnicity, so on and so forth. I draw your attention to the one in the middle of the second line, quality of life. And of course, it's not up to a committee or even your individual doctor to tell you what to do with respect to your own views of quality of life. But quality of life is a very important value in making decisions like this. But quality of life should not be a characteristic of the triage decision. Disability of any kind should not be a factor, unless that disability bears directly on the unlikelihood, the high unlikelihood of the patient surviving. And we'll talk about what some of those conditions might be. And first come, first serve. It could be the first person who might need a ventilator, may not really need it, or is much less sick than other people who come later. So those are ethically inappropriate criteria. The protocol has 4 steps, and the first step is to exclude everyone who really is not going to benefit from a ventilator because they're just too sick. They're just a cardiac arrest, you can see that, irreversible hypotension, low blood pressure that just will not respond to all conventional treatments, traumatic brain injury with no motor response. There are very precise ways of gauging brain function after traumatic brain injury. Severe burns. Over many, many decades, burn doctors have gotten very good taking into account the degree of the burn, the extent of the burn around the surface area, the organ failure, whether your kidneys are working or not, and so on. And then any other conditions that result in immediate or near immediate death, even with aggressive therapy. So those are people who are excluded. And on this colorful table, the blue basically are the people who are excluded that I just said. And then in the red, yellow, and green is an assessment during step 2 of the mortality risk. And the red are people who are really sick and have the most need of a ventilator and probably would benefit from the ventilator. And the details here are various indices of organ failure and clinical assessments, but that's what the red means, that they are the ones who should be given ventilators first. The yellow are people who should receive ventilators if there are any available, and because they're not quite so sick, but they're pretty sick. And the green are people who really don't need a ventilator, but maybe the question came up. And so the step 3 are tiebreakers. And this is where it becomes interesting, because I was very careful to explain that demographic characteristics should not be a factor. But one of the tiebreakers is this notion of, if 2 people are equal, and that's almost impossible to have 2 people equal during these, according to these measurements, but let's say they are, then the person who might be of more benefit to society would be given that ventilator. That can be very controversial, but that's one of the tiebreakers. I'll have to tell you right now, we've not, at University Hospital, we've not had to invoke any of these steps yet, but they're there in case they're needed. And then the step 4 is a reassessment, meaning that every day these criteria and the patient's clinical condition is reassessed. So what do you think? Here's another chance for you. You know, we've got dynamics of the individual autonomy versus what's best for the collective. We got people making decisions that maybe aren't our personal doctor. A lot of this has to do with your values. Some of it has to do with other things. Anybody have any thoughts about that?
So Dr. Eastwood, I did have one question from Diane Case that she gave me 2 questions. One I'm going to save for the end, but I think this one might be pertinent to the discussion we just had. And she asks that now that we're no longer cared for by our primary doctors when dying, and maybe this was exacerbated during the pandemic, do families raise more ethical concerns? I guess, are you seeing relatives being more assertive in how patients are treated, even just pre or post outside of the pandemic, or even within it?
Yeah, my short answer is yes, but it's not. It's based upon an impression. There's no studies to this effect, but I would say that the whole practice of high-end medicine has been changing for at least 2 or 3 decades. I mean, everyone knows that when you come into the hospital, you probably, if you do see your primary doctor, it's very often as that person is a visitor. Sometimes they do take care of you, but for really, really sick people, it's an intensivist or it's some kind of a specialized surgeon and so on. So that's the background upon which the pandemic arrived. And the pandemic has just aggravated that, because our primary doctor can't come in now for a personal visit. Only people who are authorized to take care of the patient can. And have we gotten more ethics consults? That was implied perhaps in the question. And it seems yes. Now, is it because of a specific aspect of the pandemic? I don't know, but yes, there are more ethical questions that seem to be arising. Was there a second part, or are we going to wait for that?
No, there's a second question, but I'm going to save it till save this one to the end, because it's a little different.
Okay. I think Joel is waving. Did you have something to say, Joel? I can see Joel. So
Yeah,
that's
Greg, I'm 84, and I also was on a triage committee, and thankfully we didn't have to meet and make any decisions. But so I think, and I've discussed with my wife, being 84, as far as I can tell, if I get COVID, I'm more likely to end up in the hospital, more likely to be on a ventilator, and more likely to die. So, and I've seen stories in our local paper about people in my age or older who say, well, if that happens to me and I need a ventilator, let it go to a younger person who, I've lived my life, I've accomplished most of what I want to accomplish. Everything is gravy now, which is wonderful, but somebody else who hasn't had that opportunity might benefit. So you struggle, because on the committee, you would not like to think you're going to eliminate the older citizens from a chance. The goal has to be really to try to pull everybody through who we can pull through. But part of me would struggle and think about letting the ventilator go to somebody else. Now, that's a nice intellectual, discussion. What happens when it really happens is another story.
Yeah.
Thanks.
No, I've heard that, Joel, and again, it's hugely value laden, isn't it? And does it make a difference if this person who receives the ventilator I might have received is completely unknown to me, or maybe if it's a friend, or even my grandson, or whatever. There's a lot of variables here, and to put something like that, as you know, implied, to put something that into a policy would be very difficult. I think it would be an individual decision, wouldn't it? If the person who receiving the possibility of a ventilator and they decide, well, they ask the question, could someone else use this better than I? Let's go on to the final section here. So here's another comic strip that I sometimes read. It's called Beetle Bailey. And here's General Half Track. This is about life in the Army, if you haven't seen it. And he's sitting there at his desk. He says, the story of my life is almost written. And he sighs, I wish I had a refresh button. And this is a riff on the Faust legend, isn't it? I mean, he doesn't say I'm going to sell my soul to the devil, but it's basically, how could I go back to close to the beginning? And no. But there are things we can do to raise this to consciousness and sort of manipulate, the narrative or the story of our life. So William Shakespeare said, the web of our life is of a mingled yarn, good and ill together. In the early 90s, I came across, just by chance, a book by the name of Stories We Live By, Personal Myths and the Making of the Self, written by a social psychologist by the name of Dan McAdams. In the very beginning, he says, a life story is a personal myth that an individual begins working on in late adolescence and young adulthood in order to provide his or her life with unity or purpose, a special kind of story that each of us naturally constructs to bring together the different parts of ourselves and our lives into a purposeful and convincing whole. Look up to that first line and look at the word myth. So often we read in a newspaper or some kind of periodical 5 myths about investments or whatever. And in that use of the word myth, that means these are untruths or understood concept. The use of the word myth here is an essential truth. It's a little bit like the Greek myths or ancient myths, or something is of mythic proportion. The myth here is something that makes sense. We constructed it in a way, it's not untruthful, but it may not be factually representative. And so I say about this, our story is a gift to the next generation. We work on our story until we die. So I ask you to think about what your story is. All of us have stories, I believe. You might disagree, and if you do, I'd like to hear it. But the story cannot, often it's a mix. It can be a tragedy, mainly. It can be a comedy. It can be very insightful. For most people, it's a mix. Mine is mostly positive. I won't tell you my story unless you ask me. I won't give you the whole story, but there are aspects of my story from early childhood related to the influences I had that made me want to be a medical doctor. So we all develop these narratives to explain things to ourselves and other people. So as we approach the last chapter of our narrative, meaning the end of life, am I satisfied with my story? Is there any unfinished business that should be attended to? And these are not specific questions. These are questions for you to interpret. Do I wish to be remembered in a little different way? Well, what if I can't write the last chapter? What that means is, what if I'm demented? Or what if I become too ill or cannot make my own decisions or contribute to my own story in some way? How do we handle that? There's that aphorism, can a leopard change its spots? No, we can't change fundamentally, I don't think, late in life, but we have a life experience of change for, what of it, 50, 60, 70, 80, 90 years. And yes, I think we can change. So here in the book I referred to, I have several suggestions in the last chapter, which is titled Finishing Our Story, just like the book is. And the first four, I think, are pretty perfunctory. I mean, they're valid and they should be attended to. First, envision various health scenarios and discuss what you might want. Sure. Reflect on what quality of life means to you and its relevance. Very important. I mean, are you a person who feels that the spark of life is the most important thing? There are people, and there are certain religions who believe that. There are other people who think that quality of life and whatever that means to you is more important than just having what I call the spark of life. Third, select a healthcare proxy agent. Make sure that that agent knows your wishes. That's the job of the healthcare proxy, is to represent you, not themselves, when you can't represent yourself. And who else needs to be involved in your life planning? These are pretty obvious: children, friends. The last three are more personal with me, and you can decide whether they have any meaning for you or not. Consider characters from earlier chapters, whatever that means to you. What it means to me are sort of reviving some of my connections of people I haven't talked to in a long time. That's connected to the next one, and tend to your nostalgia index. Even though I'm very forward thinking, I think, and I'm always planning the future, I have a very strong nostalgia, what I call nostalgia index. And I like to revisit, both personally and also in my mind, and by looking at memorabilia, important events of my past. And some of those important events I'd like to sort of put to rest. And I've done some of that in my later years. And then finally, leave as little as you can of the authorship of your final chapter to others. Again, that's very personal to me. I like to have control. Some people aren't that interested in control. So, but to me, that's important, to set things out with people I love and people I trust, so that the last chapter of my life, I hope, would unfold as I would wish it. So this is the end. We talked about how COVID has affected the end of life experience, both from the point of view of healthcare professionals and also from people who are dying and their families, people who care about them. We also talked about the allocation of scarce resources, in particular ventilators, and some of the implications, some of the value and principal implications of that. And then we talked about finishing our story. And this is the final slide. George Santayana said, "There's no cure for birth and death, save to enjoy the interval." And this is a photograph of where I am actually right now. I just said this to Scott earlier. I'm in Massachusetts at our lake house. I'm here not to abandon you, but to help celebrate the college graduation of our granddaughter in a day or so with lots of people. But this picture was taken a couple of years ago. It's in the evening. It's the view we have of this little lake. And if you look, right in the middle is a bird who's, well, we don't know which direction the bird is going, but I think it's going away and it's lifting up. I don't want to get too maudlin here, but part of me says, maybe that's my spirit that is taking off at the end of the day. Any event, thank you. I think you've been attentive, a little hard for you to tell, but I appreciate you at least coming and listening, and I'd be happy to respond to any questions or comments.
So, Dr. Eastwood, I'm gonna add my spotlight so you're not at least talking to yourself in some weird way. And Peter has a question, so I'm gonna add Peter into the mix.
Hi, Dr. Eastwood, and thank you very much for bearing with us and being here.
You look very familiar. I think our lives have crossed a couple times before.
They have. And we won't bother these people with that, but you've always been a very positive influence in my life. One of the things that I deal with, a lot of telephone calls that the FCA gets, and deal with people who in the last days. And it seems to me that one bad thing in our culture is our television shows where there are miraculous recoveries of family members in the hospital. And I wonder how you as a doctor deal with this, what I call the myth, this myth that grandma who's 92 years old and is suffering from something is going to recover. And so we'll just keep her going. And can you give her all the medication you can to keep her going? Do you ever have to say to somebody, I'm sorry, there is a point at which we can't help grandma and we have to let grandma go?
Well, that is at least that general question of letting go on the part of the family is a reason for many of our ethics consults. There are many reasons for it. Some of it has to do with certain religious beliefs on the part of the family, but I think a lot of it has to do with the acuteness sometimes, or the unfamiliarity with this territory of dying that many patients have. You know, everyone's end of life is different, even though there's some patterns that repeat themselves. But sometimes it takes families some time to get used to this very serious news. Even when someone is brain dead, usually it's after a terrible trauma or something, family needs some time, sometimes weeks, not weeks, sometimes days to accommodate that. And the medical staff and the nurses who deal with these things a lot are on a different level and they're not meeting sometimes the family like they should. So that's one thing. The other is, you know, I said earlier there was no study to answer that particular question. Well, there are several studies to answer the question of how many people survive CPR after cardiac arrest on TV versus in real life. And I don't know the exact numbers anymore, but in some particular study, let's say it was a large majority of people who survived cardiopulmonary resuscitation on television, say 60 or 70%. And in fact, it's about 10%. And that survival is not a return to the pre-existing condition. So at least on that narrow aspect of your question, we do know that having a cardiac arrest is very serious. And then to persist on the part of the family and ask for further aggressive treatment doesn't seem sensible to many of us, but that's their right often. Other comments?
Thank you. Thank you.
If anybody else has anything, I'll add as I'm getting Joel back up on the screen with us. In a former life, I worked in the film industry in New York City, and I can tell you that nothing made me think more soberly about reality than dealing in nothing but fantasy 24/7.
Well, that is it, though, isn't it, Scott? That TV and film are not in the business of depressing people, or sometimes they are, but generally you want people to feel pretty good after the show.
Yeah.
So, Greg, this idea of writing your final chapter, when I try to write anything, I'm a great procrastinator. It's not easy to write. So in order for me to think about that, I would need to have confidence that my physician would tell me when it might be time to start writing my final chapter. And so I want to advise those who are watching to think about asking their physician, or if they're getting a new physician, which is, I guess, more common now, would you tell me, doctor, when you think I have a year or less to live because of a disease? Would you make that commitment to me? Because doctors also have a difficult time talking about dying sometimes. To the point at which New York State has said they've had to ask doctors or tell doctors by law that when you have 6 months or less to live, you have to, that patient should be offered a discussion about end of life care. They can refuse to have it if they want, but I don't think there's ever been a follow-up on that, and I don't know how faithfully doctors adhere to it. But one way to think about it for all of us in our next visit is to ask your doctor if he or she would be willing to tell you. And if they say, well, I don't know, or they hedge, well, you might think about finding someone who is more communicative, who will help you, push you to sit down and think about your last chapter. I'll mute now.
Yeah. So Joel, I understand and am sympathetic with the idea that this should be an intimate conversation that goes over a period of time between doctor and patient. I think many doctors, I know many doctors are reluctant to get pinned down because they're almost always wrong when they say you have 6 months or a year to live. When they do get pinned down, they have to, because they have to sign off on the eligibility for, one thing or another, hospice care or something like that. But so I don't know. I think if I were taking care of a patient and they asked me that, I would say, let's continue to have, you are sick and death is a real possibility within months or maybe a year or more. But I don't think I wouldn't say a year. Maybe I misinterpreted what you said.
So,
Any other thoughts or questions?
yeah, I was gonna say, this actually seems like a good jumping on what Joel said. Diane's other question, which was, do you foresee a time when doctors in New York State will be able to provide assistance to promote dying? I guess maybe like a euthanasia question, like similar to Oregon, I think, right? Oregon, I think, is one of the few states that has it.
Yeah, so I'm going to interpret the question generally, not like what I just was talking about. I'm not going to set a date, okay, or a time. I'm going to say, yes, I do foresee a time when doctors in New York State will be able to prescribe deadly drugs under the law, like they do in 9 other states, plus the District of Columbia, and like they do throughout all of Canada, and by the way, several countries in Europe. And of course, that the physician-assisted death laws have come up in one form or another, but have not been passed in this state. I think someday they will. First of all, about terminology, it's very commonly called physician-assisted suicide. I prefer to call it physician-assisted death. It might be a trivial point, but suicide has such a negative connotation to it. And we think that people who kill themselves in traditional forms of suicide have a long life ahead of them. I mean, that isn't always true, but in physician-assisted death, it's pretty clear that their life is going to finish pretty soon. So this is a different way of exit from their life. So it's not exactly like traditional suicide. So because of the pejorative connotation of suicide, I like the term physician-assisted death. Some like the term medical aid in dying, MAID. It makes a MAID, interesting acronym. So you can still cure yourself, and you don't have to do what Ernest Hemingway did and go out and blow your head off with a gun. You can stop eating and drinking. As I said earlier, Diane Rehm, I mean, this has been available for a long time, but Diane Rehm in her book about 4 or 5 years ago talked about how her husband died. He was 84 or 85. I think he had Parkinson's disease for a long time. He was living in Maryland. He went to his doctor and said, "Can you kill me?" The doctor said, "I would be imprisoned if I did." So he went home and he stopped eating and drinking. And even healthy people, it takes a huge amount of self-discipline, and then after a while, discipline on the part of people taking care of the patient. But you can't have anything to drink, just maybe moistening of the lips. But very quickly, within a few days, people lose consciousness, and eventually they will die in about 10 days, particularly if they have a pre-existing illness, like most people, like they all do. So that's my way of answering the question, but I can't give you any, if you're in favor of that, I don't know that I'd be very optimistic about it happening in the next 2 or 3 years. If you are not in favor of that law in New York, then you can sort of celebrate.
Jennifer, do you have a question?
Oh, well, it went back to the one, the small conversation before that, which was telemed to me is unattractive. And when I get back this long, long list that says your results are within normal, like I'm supposed to understand what that means. And so I understand why during the pandemic, doctors went to telemed. And I lost a couple of doctors who decided to stay. That's all they're going to be doing now. And I left the practice because for me, my doctor, being close to the doctor has always been important, especially somebody I've had for 30, 35 years. And then all of a sudden, that whole scroll about being within normal limits doesn't answer any question to me at all. It has nothing to do with how I feel or what I fear or what I would do next, blah, blah, blah. I don't know whether I'm alone in that or not. I could be a baby.
Not alone. I think that's very awkward for most physicians and certainly for patients. I think telemedicine, first of all, telemedicine is not a new idea. It began in a rudimentary form in 1955, I think, from Logan Airport in Boston across the Back Bay to the Mass General Hospital for some reason related to people coming into the airport. And then it developed over the years. I was involved in Georgia when I was down there as Dean of the Medical College of Georgia, and between our facility and the prison about 20 miles away. And then, of course, it's been developed in recent years, largely for psychiatry in hard to get places and other things that can be even dermatology, actually. So there are some and in the military, in a submarine, on ship, that sort of thing. So there are some good reasons for it, but I absolutely agree. I think most people would too, that, boy, the sooner we can get back to the touching, the feeling, the personal listening, personal speaking, the better. There will be some residual use of telemedicine, I think, for legitimate purposes, just as there will be residual use of what all of us are doing right now. Rather than, we would much prefer, I would prefer to be with you in person. But I've been involved in some conferences where I'm sitting in Syracuse, this particular board is in Cleveland, some guy is calling in from Indonesia. You can't, that's wonderful.
Yeah.
I want that to keep going.
Yeah, I agree. Oh, yes, we've even grown into that with FCA of CNY, the first few times. And our wonderful Nancy Arelli, she has some programs that are, and she's our personal Zoom expert on staff, if we were a staff, but we've done a whole lot of that, and that's been great. That's been very nice.
Well, I'm happy to answer any questions or listen more, but I'm aware that I have gone way over the bargain, and I would like to be able to relieve you and go out for you to go outside and do whatever you want to do today. I guess I would say that if you want to contact me, well, I can tell you what my email is. It's pretty easy. It's Eastwood, my name, at Upstate, where I live or work. Boy, that was a Freudian slip, wasn't it? .edu, Eastwood at upstate.edu.
Thank you for that. That's wonderful.
We thank you very much.
Yes.
Thank
It's been
you.
informative and warm and very, very nice. Thank you.
Thank you very much.
You bet.
Bye-bye.
Bye, everyone. Stay well. As it were.